Our next speaker is Dr. Cara O'Brien. She's the Associate Vice Chair of Inpatient Operations at Duke Health, is a hospital medicine specialist, completed an MD at WashU and an internal medicine residency at Duke. Cara has been a major champion for applications of machine learning in healthcare and a close collaborator of, I think, a lot of us in this room, including Mark and Kat and Joe. Probably many others, has been a clinical collaborator on a lot of sort of methodological works, but has also focused a lot on how to actually integrate these tools into the clinical workflow. And I think that kind of relates to the theme of today's talk. So let's give a warm welcome to Cara.
Thanks so much. It's an incredible honor to be asked to speak to you all. I am by no means an expert in statistics or data analytics. I am, however, acutely aware. I appreciated Tristan's slide showing the pile of PubMed papers that are coming out and the need for help for busy clinicians such as myself to digest the enormous amount of data that's coming at us to help us efficiently take care of our patients. So what I'm going to talk about today is really my own personal experience in developing clinical problems for which I think there are data analytic solutions and implementing those solutions in a way that impacts patient care. So the greatest challenge in AI and these healthcare domains is not whether the technologies will be capable enough to use, but rather ensuring their adoption. I think this is really important to remember. According to this report by Cara et al., a little over half of existing predictive models or clinical data analytic tools have not been implemented in clinical practice or have only incompletely been implemented. So it's important to consider why that is the case. So as a clinician, I encounter problems every day in the trenches in which I think data analytics would actually be useful. But how do I actually successfully put together a question that you all as experts in the field can help me design a solution for? So what I'm going to talk about today is actually some key principles that I've come up with from my own failures largely in this, in doing this work, in terms of how we actually successfully develop and then implement a data analytics tool. So we're going to talk about defining the right clinical question. And again, right is in quotations here, and we'll talk a little bit about why that is. We want to create models that actually improve current practice. So we don't just need a model that fixes a solution, but doesn't actually have impact on clinical practice. I've bolded that we need to think about how we integrate that model in a work beneficial way. So if the tool work for busy clinicians or frontline providers, it's not going to be used. And then of course, managing the change associated with implementation. Right. So as the clinician facing these problems, I think it's really important to think about how we frame the question that we pose to you all to help us solve. So what defines a good clinical question? The point is not to develop a technological solution and then find a clinical question to answer. The goal should be to identify those important clinical problems and then find the right technological solution. And in terms of what's the right clinical question, it needs to be important to frontline providers and have impact to patients and or systems of care. So these can be huge problems that occur infrequently but are tremendous barriers to care for patients, or they can be problems that clinicians or patients encounter frequently that really drive inefficiencies in care. It's important to think about problems in which a data-driven approach will help. So there are problems, medicine is still an art, not a science, and there are problems for which data-driven solutions are not necessarily going to be the right solution. For example, when is it appropriate for a patient to decide that they no longer want to take a toxic chemotherapy regimen, that they would rather live their remaining days without having those side effects, even if it means living fewer days? That is based on patient and somewhat provider preference, and there isn't going to be a data-driven solution that necessarily answers that for the patient or the clinician. I also think it's important to consider certain problems. Simple solutions may actually be easier. You guys have probably all heard the myth of the NASA anti-gravity pen, in which in the early days of the space program, millions of dollars and hours were spent developing a pen that would work in a zero gravity environment, but the Soviets simply used a pencil. It's actually a myth. Both NASA and the Soviets used pencils, but I think the principle in that analogy is appropriate here. Sometimes a simpler solution is actually what's needed, and we don't trouble ourselves with developing a more complicated solution just because it might exist. And then, of course, this is something I found really important in getting things done in a large healthcare system, is being sure that your problem actually aligns with the priority care system leaders. And sometimes that means speaking the language of the C-suite and figuring out how to change the way you're framing your problem so that you're speaking their language. Why is this a priority, the health system leadership? How do you frame your problem in a way that it is important to them? So the second principle is, of course, to develop a good model, right? And you guys are all the experts in this field, so I'm not going to spend a lot of time on this, but I do want you to think beyond the area under the curve. It's really important to think also about what the real world impact is of the model that's being developed. So does it improve the efficiency of care in a meaningful way? You know, if you have a perfectly sensitive, perfectly specific diagnostic model, but it only makes that call about 30 seconds before whatever disease state makes itself apparent to everyone, is that really that impactful? Or if a particular model suggests a treatment regimen that only extends a patient's life by 1 day over the course of a disease that's maybe years in length, is that impactful? So what is the actual real world impact of the model that you're developing? And then, of course, don't forget to consider the unintended consequences of your model's performance, right? So what does it mean to be a false positive? I can tell you from personal experience, we'll talk a little bit about this when I show our example of the sepsis model we developed within the Duke University Health System, that false positives can have a huge impact on day-to-day practice. We all know about alarm fatigue, and considering the impact of that alarm fatigue to frontline clinicians is very important. Similarly, I think it's also really important to consider the impact of false negatives. So if you are looking for a certain diagnosis and you have a false negative, what is the impact to those clinicians who missed that diagnosis if they relied too heavily on that model? And then, of course, the one I really want to emphasize is thinking through how to integrate your model in a work beneficial way. And this has to start by having a really in-depth understanding of the clinical workflows for which you're trying to embed your model. In order to do so, you need to have every individual involved in that workflow at the table, and you need to understand their particular role in that workflow. You need to ask questions. So what is your responsibility in this process? How long does the step that you take in the care of the patient take? What are your individual activities and responsibilities? Where is the deviation occurring? When and why? And what information do you need to complete the task that you're being asked to do? This is all critically important in order to be able to design the ideal workflow. And then ultimately, who are going to be the users of the model that you've developed? Are they at that table? Do you understand their role? And I think something else that I've learned that's been really critical is that sometimes the current role is not what's needed in order to best implement the model. Sometimes you have to redesign the workflow or redesign a role, change responsibility in order to better implement the model. And lastly, I think it's really important to consider how you implement. And so you guys may recognize the pictures on the right from Apollo 13, again, another NASA reference. So this, one of the problems in Apollo 13 was rising levels of carbon dioxide. There were plenty of filters available in the command module, but of course the astronauts were stuck in the lunar module, and the square filters wouldn't fit in the round holes in the lunar module for the filters. And so the engineers on the ground literally had to figure out a way to fit a square peg into a round hole. And this is often what I'm doing. I'm trying to think about how do I change practice. Rather than just driving a solution into a clinical workflow, I need to think about how do I actually make that work beneficial for the users of the model so that it becomes seamlessly integrated. And the fourth principle is change management. This is true for any organization implementing a significant change in its structure. And I like to think of it in the circles of what, how, and why. So what's the problem that the model is fixing? How does this model fix it? Why is this important? And also why now? Why do we need this model implemented now? And then what are the risks if we don't do anything? Really important to build trust, okay? So demonstrating model utility is not just about showing that area under the curve diagram. You want to show the actual clinical impact to frontline providers. And it does depend on the individual's role in the care of the patient. So showing high-level system statistics, mortality, readmission reduction to your system leadership, but at the individual provider level, showing how their practice might change as a result of implementation. What are the cases that this model will pick up that they would have missed and have a different diagnosis or a different treatment strategy. And then of course, anticipate resistance. So providers like myself are notoriously value our autonomy, right? So we don't want to be cookbook medicine. We don't want to be told what to do by a model. So you have to think about how do you show the results of the model or the value of this model in such a way that still allows the provider to act autonomously. Have a clear mechanism for the users of the model, the end users, to report feedback about that model and show your response. So if it seems like there's something that's going wrong with the model, have a way for that to be reported by the end user and make it clear what you're doing about that error. And then communicate results regularly in a transparent fashion. This again is a key aspect of building trust, particularly with frontline providers, is that they see the real impact as quickly and as close to real time as possible. Here I'm showing a dashboard that we developed in partnership with DHI to show the real live implementation results of our sepsis model that I'm going to go through shortly. This is something that's monitored. It's accessible to all of the ED providers, all of our end users, so that they can see in real time what's the impact of the work they're doing as a result of using the model. So I'm going to talk again about how those 4 principles applied to one of the areas that I've really been interested in, and that is in sepsis. And we'll talk about each of these key principles. So just as a background, I think you all are aware, but just kind of to stage set, sepsis is a clinical syndrome. It's not a specific disease. It's caused by a dysregulated host response to infection that leads to progressive organ dysfunction. In layman's terms, it's essentially what happens when the body's own immune response to an infection turns on its organs and tissues. It's a huge problem, so enormous number of hospitalizations related to sepsis, and mortality, despite our best efforts, 30 years worth of research, remains astronomically high. So somewhere between 20 and 25 to 50% of patients admitted to the hospital currently with sepsis, severe sepsis or septic shock, die in the hospital. And if they don't die, they have prolonged length of stay. Many of them are discharged to long-term care facilities or readmitted to the hospital. It's the most expensive condition treated in the US healthcare system. This is actually outdated data. It was just updated recently. It continues to be the case. So when I came into this problem about 8 years ago now, this is where Duke University Health System stood. So sepsis and our care of patients with sepsis is actually what's called a publicly reported quality measure for CMS. And so our performance is reported and accessible to the public and other institutions. And unfortunately, Duke University Hospital was only providing appropriate care for about 22% of patients with sepsis at the time that we started this work. And you can see that compared to both the North Carolina average as well as the national average, we were underperforming. So why were we underperforming? It was really important to dive into the question. Again, sepsis is a syndrome. It's not a specific disease, as I stated earlier, and there is unfortunately no gold standard single test for sepsis. The diagnosis actually relies on clinical criteria and probably more importantly, clinical judgment by that frontline provider. Why is it important to diagnose it quickly? There are bundles of care that literally have to be enacted in hours in order to improve the outcomes for patients with sepsis. And we know that every hour delay in the appropriate care provided to patients with sepsis results in significant impacts to inpatient mortality. So in terms of whether or not sepsis represented a problem for which there was a data-driven solution would be appropriate, it's a very common condition. It has a huge impact to the individual patient as well as the system of care. It's extraordinarily costly, and signs of impending sepsis are subtle. They're difficult to recognize even by a very seasoned bedside clinician, but can be picked up in trends in vital sign and labs. And time to sepsis identification does make a significant impact to patient outcomes. So it's essentially the perfect question for a data-driven approach. So what did we do at Duke back in 2014, 2015 when this problem first became evident? So we implemented a single point-based predictive model for sepsis called the NEWS score. Many of you have heard of this. Very simplistic. So simple vital signs, no trends, just the last vital signs at that moment in time and given a point value. We implemented the first best practice advisor that was built into Epic at Duke University Hospital as a result of an elevated NEWS score. This would fire to the patient's care nurse if it reached a certain threshold. And that would then activate what we called our rapid response team to evaluate the patient for signs or symptoms of sepsis and enact treatment. Unfortunately, as you can see, this was a huge failure. So our PPA was firing over 440 times per day, an average of 42 unique patients. Some of those patients were having it fire over 100 times per day, just enormous amount of alarm fatigue. In addition, it had terrible positive predictive value. So only about 7% of patients whose BPA fired based on the news score actually ended up with a diagnosis of sepsis. And most of the BPAs were canceled for obvious reasons. So it was just a real failure. And we turned it off after about a year of being in place. So what was needed was really a model that could identify patients at risk for developing sepsis in a timely enough fashion to allow care to be started. Ideally, it's within the first hour of signs of impending sepsis and avoid that high false positive alarm rate. So enter DHI, and a fabulous partnership. And the solution we developed is called Sepsis Watch. I know you guys have heard about it at prior conferences, but this is a machine learning based sepsis predictive model that's deployed within Epic, which is Duke's electronic health record. And importantly, we coupled this with a dedicated Sepsis Watch team. These are the individuals, we call them the red coats, that are pictured on the right. This is a team of nurses that are our end users for the predictive model that we developed. So in terms of the technical aspects of the model development, again, I am not the statistical expert on this, but we used over 9,000 encounters that developed sepsis in our health system, curated a lot of different important variables, and then iterated on these variables to develop the model. This is the slides that Joe Futomo put together when we first developed to help explain what the model looked like. And again, you guys are all the experts in this. This is a deep learning model. Joe developed a process to impute values between timed labs as well as vital signs. It also incorporated static elements in the patient's history, as well as their baseline covariates to ultimately develop the predictive model. And this is our area under the curve compared to other commonly used sepsis predictive models, just showing that we did outperform the SIRS score, the news score that was what was in place previously, and the more recent Sepsis 3 based QSOFA. But I think this is the aspect that I was referencing earlier. When you think beyond area under the curve, how did this actually impact, or how is it projected to impact real clinical practice? So setting an alarm threshold based on what we projected to be our staffing to actually follow the model, we allowed for 3 alarms to fire per hour. That was what we considered doable by our existing nurse staffing. This model allowed us to detect sepsis a median of 5 hours in advance. That's significant amount enough time for clinicians such as myself to take action, to place orders, labs, and order antibiotics. This was the Sepsis Watch web application that was developed largely using input from the end users. So the nurses really were at the table to help design this interface and then to iterate on the design that we created. And then importantly, I mentioned that we had to change the way the workflow was constructed. This was really critical. So we created an entirely new role for nurses in order to best implement this model. They were given the autonomy to interpret the model and then contact attending physicians in the emergency department to convey the risk that the model was identifying patients with sepsis. And then we changed fundamentally the entire workflow associated with that. We created a new team of nurses with this sort of exceptional capability and really allowed them to practice at the top of their license. In terms of managing change, this is still probably one of the hardest aspects of this and something that we're still using the model we still deal with on a day-to-day basis. So first important part was stakeholder engagement. So before proceeding at all in solving this problem, we went to the leaders of the health system and said, this is a problem, right? A 22% passage for a publicly reported measure is terrible. This is something that we need your help and your buy-in. We also had frontline provider engagement all along the way. So this was implemented in the emergency department. We had the emergency department physicians, nursing staff, technicians, pharmacists, all involved in helping design the best workflow implementation. We spent a ton of time, as I mentioned, getting model and user education, regular feedback on the process, and building the actual tool. And then we've continued to report, as I showed you in the dashboard earlier, regular results to the patient. So what is the actual impact? How many patients are getting antibiotics in a timely fashion? How many patients are living as a result of the implementation of Sepsis Watch? And then I think from a provider perspective, what I found was really important was showing how this particular model impacted their day-to-day care. So we could look at shifts where providers were in the emergency department, busy emergency department. We could identify patients that didn't have appropriate care prior to implementation and then were receiving appropriate care based on Sepsis Watch. And that really hit home for some of the providers who especially felt more resistance towards change. And then this is the results at the patient or at the population level, which I'm really happy to report. And this is work put together by Mark Sendek and the DHI crew, just showing that we have significantly reduced. So a 1% reduction in mortality is enormous. And that's what it looks like we've achieved pre and post Sepsis Watch implementation. We've also seen decreased ED length of stay, which in our emergency department, which is almost always well over capacity, this is a huge impact. And then as far as that publicly reported measure that I showed you that initially kicked off this work, so we initially started back in 2014, 2015, down in the 20 percentile for Duke Hospital. We implemented Sepsis Watch in November of 2018, which is shown on the red arrow there. And you can see that since implementation, we've consistently been in the 60 to 70 percentile, which actually puts us in top decile performance nationally on the publicly reported sepsis measure. So I think this nicely illustrates a lot of the key principles that we just talked about. So defining a key clinical question for which a data-driven approach is the right approach, creating a model that not only has a good area under the curve, has good predictive value, but also improves in a substantial way clinical practice. Thinking through how to integrate that model in a work beneficial way so that it's seamless with the care of the patient and improves efficiency. And then thinking through techniques to manage the change. That's all I have for you today. I really want to thank you all for inviting me. It's been a fabulous opportunity to come here. Appreciate all my partnerships with the DHI group. We've had a lot of fabulous work and we've made a huge impact to patients. Thank you.